Good afternoon, everyone.
Good afternoon.
Welcome to the fourth and last webinar from our series, Rheumatology Revealed 2.0, Advanced Insights and Evolving Best Practices for Family Physicians, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Dr. Aniol Salami, and I am a family physician and assistant professor in the Department of Family Medicine and a medical director at the Physician Learning Program. The Office of Lifelong Learning is committed to providing reliable updates, resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. I want to take some time to do the land acknowledgement before we begin. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehio, Niitsitapi, Blackfoot, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe, Ojibwe, Saulteaux lands that are now known as part of Treaty 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I also want to talk about some housekeeping information for the seminar today. Please use the chat feature if you have a question about technical difficulties or LP programs and services. If you have a question for the speaker, Dr. Akbar, please use the Q&A feature of the webinar. Please review what has already been asked in the Q&A feature and upvote those questions that you would like answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be sent via email to all those who registered. Participants can claim CME credits and complete a personal development activity using My L3 Plan tool. For more information, you can scan the QR code on your screen. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. MainPro Plus participants can also earn additional certified credits by completing the linking learning exercise after the seminar. I now want to take some time to introduce our speaker, who I'm very excited to hear from today. Today, we're very pleased to welcome Dr. Shafiq Akbar. Dr. Akbar will share with us the latest updates and management of psoriatic arthritis. Dr. Akbar is an Edmonton-based rheumatologist and associate clinical professor in the Department of Medicine at the University of Alberta. She graduated from Pakistan and completed her residencies in internal medicine and rheumatology at the University of Alberta. She has been a principal and sub-investigator for multiple clinical research studies for rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis for different biologics and JAK inhibitor therapy. Dr. Akbar is actively involved in teaching her fellows, residents, and medical students, and she is an academic mentor of medical students and has conducted outreach clinics in the rheumatology clinic at Fort McMurray Hospital. Thank you so much for your time, Dr. Akbar, and welcome to everyone to this webinar. And I will turn it over to our distinguished speaker. Thank you so much.
Thank you so much, Aniola, Dr. Salami, for the kind introduction. And I would also like to thank everybody for taking out time to participate or to listen to this talk, and to Andrea for asking me to do the webinar series. And can you see my my screen?
Not quite yet. So I think you just have to share the screen again.
Okay. Can you see it now?
Yes, we can.
Okay, let's see. Okay, sorry. Okay, yeah, so thank you so much. And so today, this is my second talk. Actually, I did one before, so I'm very happy to be part of the webinar series again. So today we are going to talk about psoriatic arthritis, and I'm not going to talk a lot about the treatment because I think you guys already had a session on biologics just recently by Dr. Oswald, I think, last week. Any case, so we will move forward and start psoriatic arthritis. I hope this is helpful for our primary care physicians. And so with regards to my disclosures, there is no disclosures for this talk, but of course I have participated in studies and talks for other pharmaceutical companies. So I'm going to talk about psoriatic arthritis, its diagnosis, management, and manifestations mostly, and management as well a little bit. So I don't know how much do you know about psoriatic arthritis, but we get lots of referral for psoriatic arthritis. So psoriatic arthritis actually it's a chronic inflammatory disease that, as the name says, it is associated with involvement of the skin as well as articular structures and extra-articular structures. So it has a variable, very heterogeneous condition, and it was actually diagnosed or given as a separate entity for inflammatory arthritis or psoriatic arthritis in 1964 by American Rheumatism Association. And we used the classification criteria for Mole and Wright. That was the first one that was introduced for psoriatic arthritis. So, according to their classification criteria, it was somebody having inflammatory arthritis with psoriasis and rheumatoid factor to be negative. I don't know if you guys remember that when we talk about inflammatory arthritis, we always say rheumatoid arthritis and seronegative. So seronegativity means that you do not have rheumatoid factor and ANA positivity. So when those are negative, it's considered as seronegative, although now we do have anti-CCP as well as part of it. So in seronegative inflammatory arthritis, I don't so there are five different types of seronegative inflammatory arthritis. So the prototype of seronegative inflammatory arthritis is ankylosing spondylitis. Then we have psoriatic arthritis, we have reactive arthritis, IBD related arthritis, and we have undifferentiated arthritis. So the basic difference between this seronegative inflammatory arthritis and rheumatoid arthritis is that in seronegative we do have the involvement of spine is axial skeleton, which is not part of rheumatoid arthritis except for the C-spine involvement. So in psoriatic arthritis, previously we used to say that we had like 6 domains that that are affected, but now IBD and uveitis is also included as part of the domain. So you may see somewhere it's written as 6 domains, somewhere as 8 domains. So it can be in this, so different domains that we are going to talk about later on. And as with any other type of inflammatory arthritis, there are comorbidities associated with psoriatic arthritis as well. So regarding the domains of psoriatic arthritis, so we have peripheral arthritis, and there are different ways that it can present that I'm going to discuss later on. Enthesitis, I don't know. For enthesitis, it means that wherever your tendons or ligaments are attached, inflammation at that site. So enthesitis is basically characteristic of seronegative inflammatory arthritis. We generally do not see enthesitis in rheumatoid arthritis. And with regards to dactylitis, dactylitis is the same as we used to call as the sausage digit, in which you have generalized diffuse swelling of a toe or a finger. That is because of the inflammation around around the joint as well as the tendons on the extensor and the flexor surface of the digit. So as a result, the whole digit appears big and swollen. So that is called dactylitis. And dactylitis is a very prototype of psoriatic arthritis. It can be seen with other seronegative arthritis as well. And then, as I said, axial disease can be involved anywhere from, say, spondylitis to sacroiliitis. Any part of the spine can be involved. And some people consider shoulders and hip joints as part of the axial disease. And in some, it may not be considered as the part of the axial disease as well. And then, of course, psoriasis is part of it. And when we talk about psoriasis, it's a skin condition, and nails are part of the cutaneous or the skin. So it can also have the involvement of the nails. And then on top of that, patients can have uveitis, as we know that in ankylosing spondylitis, you can have uveitis as well. And IBD is inflammatory bowel disease. The Crohn's is associated with psoriatic arthritis as well. And actually, psoriatic arthritis patients on their own, without a definitive diagnosis of Crohn's, they can also have what we can call it as macroscopic colitis in about 50 to 60% of the patients. So with regards to comorbidities, as with any inflammatory condition, if you have prolonged inflammatory condition or the inflammation ongoing in the body, it can affect the different organs of the body. So cardiovascular involvement, that is because of the low-grade inflammation that is ongoing, and you can also have the involvement of the bowel disease. You can have osteoporosis. You may have metabolic syndrome, and metabolic syndrome could be because of the diabetes, obesity, hyperglycemia, and the patients can also have fatty liver. I don't know if you guys have noticed, but psoriatic arthritis is generally patients are a little bit on the higher weight size or towards obesity or high BMI. So, and those patients are more likely to develop psoriatic arthritis. And of course, that is part of the metabolic syndrome and autoimmune eye disease as well. So that would be uveitis, but there are other forms of eye disease as well. So with regards to prevalence and epidemiology of psoriatic arthritis, so prevalence of psoriasis and psoriatic arthritis is variable in different geographic distributions, and whites are 2 times more likely to have it than other ethnic groups. So psoriasis itself in the community is about 2 to 3%, whereas the psoriatic arthritis is 0.3 to 1% in US population. And so of all the patients who have psoriasis, out of those, it is about 7 to 48%, 42% of the patients can have psoriatic arthritis. So generally we take, like we say, around 30% of the patients with psoriasis would have psoriatic arthritis. This was a Canadian population study from 2019 that reported a cumulative prevalence estimate of psoriasis up to 15 per 100,000 population. Now, with regards to pathogenesis, like what is the underlying pathology? So even in patients who have psoriasis and do not have psoriatic arthritis, if you look at the bone signals or at the enthesial point where the ligaments and tendons are attacked, you can still see some radiographic changes on some, say, CT scan or MRI kind of a thing or on ultrasound without having actual psoriatic arthritis. And the cytokines that are generally involved, so far, we all know that the most important cytokine is the tumor necrosis factor, which we are aware of for a long time, and we know that these medications, the anti-TNFs, they work very well for inflammatory arthritis, including psoriatic arthritis. The other cytokine is interleukin or the IL-23, 12, 23, and IL-17. We have few agents available that use this pathway to treat the disease. Phosphodiesterase phosphodiesterase 4 inhibitors, which are also play some role in psoriasis and psoriatic arthritis. And then the latest pathways that have been discovered are the JAK-STAT pathways. And there's another thing. There's some evidence that trauma and infection can play a role in say flare of psoriatic arthritis, or it may become like first manifestation in about 25% of the people. So I mean, we do come across patients who come to our clinic and say, "Oh, I had this kind of a trauma, and since then this arthritis started." So, which of the following is true about psoriatic arthritis? So, it's a poll question. Psoriatic arthritis can develop at any age, but commonly between 30 to 50. Psoriatic arthritis is like any other inflammatory arthritis. It affects female as a preponderance for females. Or number 2, psoriatic arthritis commonly affects men. Or number 3, psoriatic arthritis seems to affect men and women equally. So, what do you guys think? Okay, the answer is number 3. Psoriatic arthritis seems to affect men and women equally, actually. With rheumatoid arthritis and other type of arthritis that is more common in women, connective tissue disease is more common in women, but psoriatic arthritis is a type of arthritis that is equally distributed between men and women. Good. Okay, sorry, there are 2 questions side by side. So these are, unfortunately, I think that I should have put it in a different way so that we could have done the polls. So which bacterial infection can predispose to psoriasis? That is one question. And if it predisposes to psoriasis, what type of psoriasis can it cause? I mean, I haven't even discussed about the type of psoriasis, so I think ideally this should have been a little bit later, but that's fine. If you have the answer, just answer it, please. Um, I think we can move forward. I don't know. I don't see anything. Um, so the answer is the infective agent is streptococcal pharyngitis, and the type of psoriasis is guttate psoriasis. So we'll talk about that a little bit later. Okay. So again, with the type underlying pathology, so psoriatic arthritis is a little different than rheumatoid arthritis. In rheumatoid arthritis, when you have the involvement of the joint, there is no new bone formation. There are erosions or part of the bone is eaten away, but there is no new bone formation. But in psoriatic arthritis, you can have two type of responses. Most commonly is the new bone formation, and that is called periostitis or at the joint, and or you can have a response in which you have more of a breakdown of the bone or more osteoclastic activity. So in one you may have more osteoblastic, and in one you have more osteoclastic activity, and that leads to ankylosis and syndesmophyte formation if there's new bone formation. And even in patients who have that's okay, we'll move forward. So, with regards to prognostic factors associated with a worse outcome or radiographic changes, is if the person presents with more of polyarthritis, they have more structural damage, if they have high inflammatory markers or dactylitis or nail involvement, that is more associated with worse prognosis. And so, with regards to classification and clinical manifestations of psoriasis. So, psoriasis is the skin involvement, and again, we have like different types of psoriasis. The type of eruptions that you can see, and we can also have the nail involvement. And so 80% of the patients would have a mild to moderate skin disease, and 20% would have moderate to severe. And in about 10 to 15% of the patients, they do develop psoriatic arthritis in the absence of psoriasis. So we call it as psoriatic arthritis semi-psoriasis. The thing is that basically, how do you then you can say that how do you call it like psoriatic arthritis semi-psoriasis? It is by the pattern recognition how their joints are behaving. So if their joints are behaving, say if the person has dactylitis but does not have any psoriasis or monoarthritis of one joint, then upon the presentation of or the selection of the joints, then you can make the assumption that this patient would develop psoriasis down the road. So these are the various types of psoriasis. So if you look at the left-hand side of your screen, where you have on the top this is called the plaque psoriasis, in which you have big patches of psoriasis, thickened skin, roughened skin, scaly. This is called plaque psoriasis. This is the most common type of psoriasis. Then the picture next to it, it is called the guttate psoriasis. These are tiny, like teardrop type spread all over the body. This is the type of psoriatic arthritis psoriasis that can be precipitated by streptococcal pharyngitis. And the picture next to it on the right hand side on the top is the palmopustular psoriasis, in which you have the pustules develop on the palm as well as the soles. Sometimes this type of presentation of psoriasis can actually be a side effect or paradoxical effect of anti-TNFs as well. In the bottom row, we have on the left hand side, we have the inverse psoriasis. So the psoriasis in the intergluteal area, intertriginous area, in the armpits, in the groins, in the periumbilical area or the umbilicus behind the ears. So in patients in which you think that they may have psoriatic arthritis, but there is no obvious signs of psoriasis, so it's important to look in those areas. And I mean, generally in our clinic, we do look at the periumbilical area and behind the ears, and you can generally get some idea about the skin disease. And next to it is at the diffuse erythematous psoriasis, that is called the erythrodermic psoriasis. This can be very severe, and there's marked erythema and warmth to the skin. And actually, I had one patient who lost his life because of a flare of erythrodermic psoriasis. So that is the worst form of psoriasis. And the last picture is showing nail psoriasis. This is not a very good picture. It does not show all the features of psoriasis, psoriatic nail changes, but you can see a little bit of onycholysis and some hyperkeratosis on the index finger, a little bit on the early changes on the left fourth finger as well. So With regards to severity of psoriasis, so it the way it is classified as severe, mild, or moderate is on the basis of the body surface area. So one body surface area is equal to the palm of the patient. So if you have like less than 3 body surface area, then it is considered as mild, and if you have between 3 to 10, it's moderate, and more than 10 is severe disease. And generally, psoriasis predates about by 7 to 12 years before the patient develops arthritis. And in about 15%, it may be simultaneous, and in 15%, it may evolve later on. And sorry, this one we can skip for now. So with regards to classification criteria for the diagnosis of psoriatic arthritis, by now I think you guys must have heard several times that the classification criteria that we have, generally they are for the enrollment of patients in clinical trials rather than for the diagnosis of the disease. But most of the time we still use these classification criteria as your diagnosis as well. So according to Casper classification criteria that was proposed in 2006, so anybody who has inflammatory arthritis, meaning they have like swollen joint or the spondylitis or they have enthesitis, in addition to that, if they have 3 points, including either a current psoriasis or history of psoriasis, and nail dystrophy, and sorry about that, nail dystrophy, including onycholysis, pitting, or hyperkeratosis, and they are rheumatoid factor negative, so there's a point for that. Dactylitis has a point, and if you have any radiographic changes, that has a point. So if you have like 3 points plus the inflammatory arthritis, then the specificity is actually quite good at 99%, and sensitivity is 92% for psoriatic arthritis. Now, with regards to psoriatic arthritis itself, how does it present? So it generally presents in five different ways. The most common presentation is generally the diffuse asymmetric polyarthritis, the way it presents with rheumatoid arthritis. And the other presentation that is common is oligoarthritis, meaning less than 5 joints involvement. And most of the time in psoriatic arthritis, you have more of a lower joint, lower limb involvement, so ankles or the knees, and that is oligoarthritis. They can also present as arthritis involvement of the DIP joints. DIP joint involvement is almost always when the patients have nail psoriasis, because the nail bed is just adjacent to the DIP joint. And arthritis mutilans is a type of arthritis which is a very destructive type of arthritis. It's not common at all, less than 5%, I think. I have in my practice like 2 patients who had arthritis mutilans, and these are the patients when we did not have any good treatment. So that leads to destruction of the bone. And the last type is if the patient has psoriasis and just has spondylitis, no other thing but except for spondylitis. So that these are the 5 different ways that psoriatic arthritis itself can present. And so most patients with psoriatic peripheral arthritis have severe psoriasis. So this is a poll. What do you guys think? Good, excellent. So you guys know it already. So yes, majority of the patients with psoriatic peripheral arthritis do not have severe disease. And so most of the time they have mild disease. And I think as rheumatologists, we mostly see patients with milder disease or psoriasis rather than severe arthritis. And what are the risk factors for transition from psoriasis to psoriatic arthritis? As I said earlier, I think one of the slides that if you have nail psoriasis, scalp psoriasis, inverse psoriasis, they are more likely to progress to psoriatic arthritis, and we have to look in the hidden areas in order to check for psoriasis. So this is the same thing. This is from a corona registry that is in United States that less than, I mean, the majority of the patient, like 68 or 70% of the patients would have low body surface area with psoriasis, and few would have like moderate psoriasis, or severe is even less common. And so this is a type of, just some examples for different types of psoriatic arthritis, the way it presents. So this is, I wish we had the poll and you could have pick up like what type of arthritis is it. But if you look at it, it is called the DIP joint involvement. It is not like symmetrical all over, but you can see bilateral third DIP joints are swollen, and you see that they have the corresponding nail also has psoriatic nail changes with onycholysis, and in this one too, the nail is being separated from the base of the finger, and there's a little bit of activity on this joint as well as at the right thumb. So this is called DIP joint involvement. And so if you look at this one, if you did not have the skin rash or on the dorsum of the hand, you would have said that this patient has rheumatoid arthritis with swan-like deformity of the joints. But this patient has psoriatic arthritis, and the MC joints are swollen, and you can see, I mean, I don't think this DIP is the DIP joint involvement. It is more of the laxity of the tendon, and as a result, you have that changes. So this is the polyarticular rheumatoid type presentation. The wrist joints at the ulnar steroids are prominent as well. So there must have been some inflammation so at the MCPs as well. So this is another type of arthritis that is called dactylitis related psoriatic arthritis. So the second toe is all swollen all along. And this is what is known as the sausage digit or psoriatic or the dactylitis. And you see on the first toenail, there are some psoriatic changes, but it's not a very good picture. And the patients can also present with enthesitis, in which you have inflammation at the site of insertion of the tendon or ligament. So at this one, it's Achilles. You see on the left-hand side, you don't have any involvement. On the right-hand side, it's bigger and swollen, and it obviously looks different. And sometimes if you do the ultrasound, then you'll see the inflammation. Sometimes it could be like more of a chronic changes. Sometimes you can also see retrocalcaneal bursitis. So there are a few things that you can see. And this can be seen in about 20 to 40% of the patients. And the common sites for enthesitis are Achilles tendon. Plantar fascia is another common one. And wherever your ligaments are and tendons are attached to the pelvic bone, so the iliac crest on the sides of the pelvis, that you can have a patient can complain of pain, not exactly over the SI joints, but over the pelvic bones. And you can also have like lateral epicondylitis, medial epicondylitis. Those are other areas. And so this is what is known as arthritis mutilans. So in which you get the destruction of the bone. I think there would be a picture of X-rays further down in the presentation that we will see afterwards. So in these patients, this is known as the telescoping of the digit, because it is almost like a telescope, and you can actually pull the digit. If you hold the finger from distal end and you try to pull it, you should be able to pull it like in this picture, because just because of the destruction of the underlying bone, you don't the digit has become smaller, and so that can be seen about 5% of the patients. So this is what I was telling you earlier, that there are two types of changes pathologically. Either you have osteoclastic activity or you can have osteoblastic activity. So on the right hand side, it's the bone is in red is the osteitis, meaning there's inflammation on the bone, and depending upon which pathway is triggered, if you lose the it's more of osteoclastic activity, then you get the arthritis mutilans, destruction of the bone. Whereas on the left hand side, you have more osteoblastic activity, so you get the new bone formation, or the osteitis, or the enthesiophyte formation at the bone. So most of the time when you see patients with psoriatic arthritis, especially if they had the dactylitis or involvement of the toes, then even after inflammation has resolved, everything is settled down, you can still see that there is some, the base of the base of the toe becomes wider. So you can make an presumption that the patient had psoriatic arthritis in that digit. Now, nail psoriasis, we already, so nail psoriasis can be seen in about 60 to 80% of the patients with PSA, and it generally occurs generally occurs 1 to 2 years before the joint involvement. And you can have ridging, you can have pitting. So in this picture, you can see the ridging and pitting and onycholysis and hypertrophy of the subungual area. And yeah, so those are the nail changes. With regards to axial involvement, so involvement, it can be either the involvement of the spine or the SI joint. Similarly, in ankylosing spondylitis, you can have spondylitis part, that is the spinal involvement, or you can have sacroiliitis. So both things are common. Both things can be present, or it could be just a continuous thing. So the spondylitis, and this can be seen in about 5% of the patients. And if you do an X-ray or the MRI of these patients, with even those without any symptom, you can see in 1/3 of the cases that there might be some radiographic changes. But as we are aware, the radiographic changes do not go hand in hand with the clinical symptoms in any of the things, whether it be spondylitis, whether it be osteoarthritis, in any of those presentations. In ankylosing spondylitis, if you remember, we have an SI joint involvement that is symmetrical, whereas in psoriatic arthritis, it's mostly asymmetrical, but it can be bilaterally symmetrical, especially in patients who do have HLA-B27 positivity. They tend to have more bilateral sacroiliitis, and C-spine involvement can be there, just like rheumatoid arthritis. When these patients are going for GA or general anesthesia, then they should have the C-spine X-ray in order to rule out any evidence of atlantoaxial subluxation. And with regards to IBD, these patients can have subclinical bowel inflammation. As I said, they can, about 60% of the patients can have it, but they can also have Crohn's disease with interleukins that are generally involved are the IL-23, 12, and T helper cells 1 and Th17 responses. Now, uveitis is another thing. So if you have a patient who has a history of uveitis and now they started complaining of joint symptoms or the back pain, you should think about, could it be part of inflammatory arthritis? Again, the eye can be involved. Any part of the eye can be involved, including the keratitis or conjunctivitis, or scleritis and uveitis. And this can be seen in 10% of the patients with psoriasis and 31% of the patients with psoriatic arthritis. And the common type of uveitis that we see in spondyloarthritis is called acute anterior unilateral uveitis, whereas in psoriatic arthritis, you can have either acute anterior uveitis, especially in patients who are HLA-B27 positive, so they are presenting more like spondylitis, or in patients who are negative, then you can also see them to have more of a chronic insidious onset bilateral anterior or posterior uveitis. And then, of course, those should be treated, or those patients should be sent to ophthalmology for further treatment. And what are the lab investigations? So actually, there is no specific lab for psoriatic arthritis, as we don't have any antibodies. In fact, if you don't have the antibodies, that would give you an extra point for possible psoriatic arthritis. With regards to inflammatory markers, ESR, CRP can be elevated. You know, ESR we don't order anymore, but CRP can be elevated, but not always. And then you have typical other changes of chronic inflammation, anemia of chronic disease, or hypoalbuminemia, or ferritin level may be elevated, but not commonly. And hyperuricemia can be seen in patients with psoriatic arthritis. I wish I had a poll question for that. What does that? These patients are predisposed to what type of other inflammatory arthritis? I don't know if you can write it in the chat box, but I don't know how to access it. So these patients with psoriatic arthritis are more prone to gout. Okay. So this is the X-ray finding. So if you look at the X-rays of this is the bone. So if you look at the PIP joint, you can see that there's new bone formation, anticified formation at the thing. There's some destruction of the bone. So if you look at the, and the hand on examination, it would be wider at the PIP joint. And so there's some periosteal activity. So this is what you can see with psoriasis. And so on this, the foot X-ray, you see on the right-hand side, the first toe, the first phalanx, or the proximal phalanx, is missing. So that is the type of arthritis mutilin. So that is because of destruction of the the bone completely, and then you have the erosions and some damage done to it, and this is called arthritis mutilans in imaging. With regards to comorbidity, so we do have cardiovascular involvement or worsening of changes. So EULAR is European League Against Rheumatism. So they have their guidelines for the management of cardiovascular risk in inflammatory arthritis diseases that was updated in 2016. But generally, it is a recommendation that patients who have rheumatoid arthritis, psoriatic arthritis, any of those, that they should get routine every 5 years or so cardiovascular risk assessment. I mean, as rheumatologists, we generally do not do it, but when we have a new patient that has been diagnosed with psoriatic arthritis or rheumatoid arthritis, I generally write on my letter to kindly monitor this patient for cardiovascular disease. And so that is, I think, on your part to work on it, and we will try to treat the disease itself. With regards to liver disease, yes, we already said these patients generally have more high BMI, so they could have a fatty liver on its own, or they can have non-alcoholic fatty liver disease, and this is generally proposed to be secondary to insulin resistance. And again, we do have some medications that can also cause liver enzymes to go up or cause liver damage, like methotrexate and leflunomide. In the United States, they don't use leflunomide very commonly for psoriatic arthritis, but we do use it. And with regards to malignancy, in malignancy, we have lots of studies over and over again. They do not show any increased risk of malignancy with the medications generally, but any inflammatory arthritis, any inflammatory condition does lead to increased risk of cancer on its own as a part of the disease activity, especially lymphoma. But some type of skin cancer may be a little bit higher in patients on biologics, especially the TNF inhibitors. But generally, the prevalence is almost the same as with, say, rheumatoid arthritis. So for family physicians or primary care physicians, when to refer the patient? So initially, I mean, the thing is that if you think that the patient has inflammatory arthritis, then you should make a referral to rheumatology. It especially becomes, I mean, with regards to treatment, generally we are there to treat the patient, but sometimes patients are in remote areas where you do not have easy access to a rheumatologist, or the patients do not have the way of coming to the cities. So in that case, maybe you can use I would say in that case that you call the rheumatologist on call, and then they can discuss the management over the phone, or we can do a teleconference or something like that. So with regards to our medications, most of the time, I think all the rheumatologists should do that. They monitor their own labs when they start the patients on certain medications, but it's always CC to the family physician, so that we have two people looking after the same thing. So that's good. The other thing is that sometimes you may have patients that fail to follow. They do not show up for their appointments for a long time. And there's no way that we would know it unless somebody approaches us. So if you see, say, blood work or something like that, or the patient is not taking the medication, it's always very helpful if you can send a note that this patient is not taking medication or has failed to follow up, and then we try to see the patient as soon as possible. And as I said, if you're thinking about seronegative inflammatory arthritis, then look at the skin to find out any signs of psoriasis. And with regards to biologics or the advanced therapy, that is generally prescribed by the rheumatologist. But of course, you may come across patients that may get some side effects from those, and like infection or something like that. So it's always very useful that you let us know if there's a problem with that. And so this slide was not prepared by myself. This is from a pharmaceutical company, and this is just the patient reported outcomes. So patients who have psoriatic arthritis, so they complain the major issue for the patient is the joint pain rather than the skin on its own. So 32% of the patients, they complain of joint pains as a major problem. And of course, when you have ongoing inflammation, you have fatigue, you have physical dysfunction, and lack of motivation. So those things are there. And as we've already talked about, that psoriasis is generally mild in patients who have psoriatic arthritis, and the I mean, this is the reality of MSK symptoms. So, despite of treatment, all medications, so 53% of the patients may still complain of pain. So, there might be some unmet conditions or things that we don't know or which are difficult to treat that the patient may be suffering. Um, this is basically just from the corona registry. It basically tells you that, I mean, the black bars are the patients who are on biologics versus the patients who are not on biologic in general population. So, of course, those who are on biologics, they tend to have everything more so the nail psoriasis, enthesitis, dactylitis, because those are the patients who are more severe, and as a result of them, they are on biologics. So, those features are more common in those patients. Okay, and this is basically the inflammation of the joints are predictor of joint damage. So you have persistently swollen joint, then it's more likely that they would get underlying bone damage. And so swollen joints is a big thing. We don't want anybody to have swollen joints. We want to fix it as soon as possible. And greater activity is associated with progressive damage. And so the goals of therapy are generally to reduce inflammation and pain, prevent joint damage, improve quality of life, and manage the symptoms. So for the management of psoriatic arthritis, the first thing is that we need to have the diagnosis. Then depending upon the clinical manifestations of the patients and the comorbidities that they have, and whether they are in reproductive age or patient preferences. So there are lots of things that come into play in order to cater the or tailor the treatment. So if the patient does not have faith in the treatment that you are giving, it's unlikely that they would be taking it regularly, or they would be compliant in taking the medication. So you have to have that understanding, or the patient has to be in agreement with whatever you are prescribing them. And so, like rheumatoid arthritis, we are trying to do the treat to target approach. So we try to treat it as much as we can. We don't like people to be living with low disease activity or moderate disease activity. So long-term remission is possible in 70% of the patients with psoriatic arthritis. And with regards to treatment options, so we have some conventional synthetic DMARDs, most commonly methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. But remember, with hydroxychloroquine, there's a very tiny risk that it can flare psoriasis itself. So some people don't use it. And the most commonly used ones are methotrexate and leflunomide. I use sulfasalazine pretty commonly as well. And then we have the biologic agents. We have the anti-TNFs, several of them, as well as IL-17 blockers and the JAK inhibitors. And this is the same thing. So in biologic DMARDs, so anti-TNFs, there are a few of them that you are familiar with. Then IL-17 inhibitors, IL-23 inhibitors, they work better for skin as compared to arthritis, although some of them have been approved. Most of these are approved for arthritis as well. The IL-23 inhibitors do not work for patients who have just spondylitis, but they would take out the skin, but not the spondylitis. IL-17 can be used for all manifestations. JAK inhibitors can be used for, both these can be used for all manifestations. And whatever. So this is basically, this is a very good slide, but I don't think we need to go over this because it just tells you like what treatment to go and what is the what happens when if one treatment doesn't work and we have to move on to the next one. I think this is something that we'll be doing. And of course, we do have like intraarticular cortisone injections can be used as well if somebody is presenting with monoarthritis. So the drivers of the psoriatic arthritis disease, some genetics, some biomechanics, metabolism, microbiome, and alcohol intake and smoking. And manifestations, we already discussed about it. And consequences, the thing is that we have to treat the disease and avoid any long-term consequences or side effects. So conclusion, it's psoriatic arthritis is a complex disease. It can involve multiple domains. We do have treatment available, and we try to do treat to target. And currently, I mean, the thing is that most of the time we need a rheumatologist and dermatologist and plus minus a gastroenterologist in the management of these patients. And we still don't have all the ways of figuring out which patient is going to respond to which medication. So there are new therapeutics in for the pipeline. Good. I think that's all for now. Thanks a lot. And you can ask the questions.
Wonderful. Thank you so much, Dr. Akbar.
Very welcome.
And so we have our first question here. Do you treat hyperuricemia to decrease risk of chronic kidney disease or gout if they haven't manifested into clinical gout yet?
No, generally not.
Okay, generally no. And then yes, feel free to put more questions in the chat.
I don't know. I mean, from a family physician's point of view, because I called a family physician that I knew yesterday, last night. I said, "Is there anything? I mean, is there any particular questions that you come across in your own clinic?" But I didn't get any answer. So I don't know what you guys would like to know, or what are the things that you come across or struggle with.
So before I have a question, so I'll pose a question. One thing that has come up for me a lot with patients is asking about a lot of prevention. So they often will, when they get the initial diagnosis, a lot of them are very, in my experience, very worried about the arthritis mutilans in particular. So really worried about functional loss of the hands. And they often ask me like, Doc, are there things that I can eat differently dietarily? Can I do physical therapy? Like, what evidence is there around preventive things to do that are not medically established, so to speak? Do you have any insight on what individuals do in terms of conservative management? So things that don't involve pharmacology and so on and so forth.
Okay, so the most important thing is that you have to get your arthritis treated. That is number one. You can get your arthritis treated with other non-medical stuff, right? So just by dieting, just by exercise, just by physio or the vitamins, you are not going to fix it. I just had a patient today. I mean, she's just massively swollen knees and she just wanted to do some natural stuff. She has done it for a couple of years and she's not destroying her joints. So we have to give them a lecture on that, right? Yeah, with regards to diet, there's no specific diet, but the diet that has been studied the most is the Mediterranean diet that has some anti-inflammatory effect. With regards to physiotherapy, yes, if patient has like swollen knees or something like that, or the hands, it's good to have some physiotherapy going because we don't want to lose the muscle mass, right? So that is recommended, but again, that becomes a problem because physiotherapy is not covered, unfortunately. And if we do have physiotherapy at the university hospital, but the problem is that we just discussing yesterday, even if you have a patient who have active myositis, right, that you want them to get the supervised physio, they don't have an opening. So that is basically wasting. I mean, they say that they are very busy. So that's a problem. They don't have the resources. They have like one or two physiotherapists for so many patients. And most of the patients cannot afford it. But physiotherapy would be good, yes. But that is not going to fix the disease.
Yeah, absolutely.
Yeah.
Thank you so much. So we have another question here, asking about the chronic pain. So how is the chronic mask pain treated when when they are already on good PSA treatment?
Well, the thing is that PSA is, as I said, it's more common in patients who are overweight, right? So it's very difficult to tease out if these patients have more of a fibromyalgia type of a chronic pain or if it is disease activity itself. So if they have more like soft tissue pain or something like that, it's just, I mean, the exercise is the best thing. I generally do not use Cymbalta or anything like that, but that can be tried. But I mean, if everything is good, the joints are good, everything is then, I mean, if the patient's pain is not settling down, then we send them to the chronic pain. Although, basically, I would say just encourage them to do physical activity and stay active. Do not get restricted by the pain because the chronic pain does not affect anything negatively. The chronic pain, soft tissue pain, does not damage your joints.
Mm-hmm, mm-hmm, mm-hmm. Thank you for that.
No
We
problem.
have another question in the Q&A, asking about uveitis recurrence management and whether or not you would involve an ophthalmologist first or a rheumatologist.
So if you have uveitis, even if I have uveitis patients, I always involve ophthalmologist because we do not examine the eye. I don't. We don't use ophthalmoscope to check for the eyes. So I always involve the ophthalmologist. Now, so it's quite often we got referred from the ophthalmologist that they have a patient with recurrent uveitis and they say, oh, is there a rheumatological condition for that? So there is treatment for uveitis. We have biologics, we have methotrexate, depending upon how bad it is.
Mm-hmm. Thank you
Yeah,
for
so
that.
there is treatment available. So
Mm-hmm.
anti-TNFs generally work for uveitis, The most common, the best one is the Humira or its biosimilar. Infliximab can be used, but the one that we don't use is etanercept or the Enbrel it used to be, right? Or its biosimilars. And the newer medication like IL-17 blockers or the JAK inhibitors, they haven't been shown to work for uveitis.
Hmm. And just to follow up to that initial question, generally speaking, have you seen ophthalmologists initiate biologic, or do they usually reserve that for the rheumatology colleagues?
No, we are the working class for ophthalmologists. They don't use any of those. I don't know why. Ideally, we should have a discussion that why don't they use I mean, the medication, they should start using it, but they just use us to do that,
Okay,
which
fair
is
enough.
which is sad.
Fair enough. Thank you for that clarification. And then we have another question. What would be the significance of isolated recurrent episcleritis in an otherwise healthy patient where you don't see skin and joint involvement? So, asking about whether or not you can have an isolated episcleritis and how you would work that up.
So that again, that is not for us, right? That is the ophthalmologist who's going to make that decision. And so scleritis or episcleritis, I don't think they do much about it. But if it's a scleritis, then we have the same thing, the methotrexate or something like that, that can be used.
Okay, yeah, so that would probably be ophthalmology that would do the
Ophthalmology, yeah.
monitoring and
Yeah,
assessment.
I don't make the decision. If that happens, then I will ask the ophthalmologist if they want me to initiate the systemic therapy, then I can.
Hmm.
But I don't monitor it.
Fair enough. And then we just had a request in the chat if we could see the second last therapeutic slide again, to answer a question around counseling the patients about appropriate therapeutic options. So I believe it's the second last therapeutic slide that the participant was wanting to
This
see.
one?
Yeah, I believe so.
Okay, good. I'm
Yeah,
impressed.
yeah. So I think that they just wanted to take a look at it for a second
Sure,
time just to
sure.
read it over.
Absolutely.
Okay, and then I'm just monitoring the Q&A for any other questions. So if folks still have questions, please feel free to throw them into the chat. We do have some time still yet. But it is interesting to see like the interplay between different specialists, right? The idea of like there's certain pieces for ophthalmology, certain pieces for rheumatology, and that interplay and crosstalk.
Yes,
Um,
absolutely. Yeah. Mm.
yeah, yeah. So do you often find that you're working very closely in teams, so you're
Yes, we
interspersing
do.
between
We
yourself
do. Like sometimes it would happen that, oh, okay, I have a patient whose arthritis is very well controlled, but skin is bad. So
and
as a rheumatologist, I cannot change the medication on the basis of the skin change, disease activity. So then I would refer them to a dermatologist that if you want to change the medication, then you can.
mm-hmm.
But then we try to pick something that works for both.
Mm-hmm.
Now,
Mm-hmm.
the latest one, the IL-23 inhibitors, like Skyrizi and those medications, they work very well for psoriasis. I mean, their PASI scores go around 100%. Yeah, but
Mm-hmm.
those do not work very well for arthritis.
Mm-hmm. Mm-hmm. If there aren't any other questions in the Q&A, I wanted to ask another one. Something that I often think about with these conditions that can often cause either functional loss or changes to appearance, so disfigurement, is around the mental health and the chronic disease or illness experience. And so, in your experience, how have you mobilized supports around individuals who have like severe disease progression, where they have functional loss, or they may have, if they have psoriatic, also skin manifestations, it can affect their hair and their skin and their nails and their overall appearance. What has been your experience in terms of mental health support and helping people cope with their illness experience?
Well, that's actually a very good thing. I mean, good question in the sense that psoriasis itself, if you have skin disease, right, that is very disabling for the patient and it can be very traumatic mentally. And so I would generally, sometimes the patients, they come and they say, oh, I just cover my skin with, say, clothing or something like that, right? I always tell my patients, nowadays we have so many therapeutic options that nobody should be living with psoriasis on the skin. You
Mm-hmm.
should see the dermatologist because lots of people just don't care, right? They just get used to it. They were like ongoing for 20 years. They think that there's no treatment options, but we have very good treatment options. And I always tell them to, I would myself, I would just refer them to the dermatologist if their arthritis is not bad, that this patient is suffering, please treat them. And there's treatment. And the other thing is with the psychology part of thing, I think one of the family physicians that I know is a patient of mine. She's doing as working as a psychologist, right? So I sent the patients to psychologist if they need it, right? I don't know if I don't think there's any referral required for that. We just give them the website and they can access themselves.
Mm-hmm.
Mhm.
Mm-hmm. Thank you very much.
No problem.
And then are there any other questions from the group? If so, we can take a look. But just while we're waiting for that to trickle in, I would like to encourage everyone who enjoyed this webinar to please take some time to give us some feedback. So you can see the QR code on the screen. You can also see the link there for how you can actually give that feedback. We really appreciate you telling us about how these webinars go. We do incorporate feedback from year to year. So we would sincerely appreciate it if you take a few minutes to complete the evaluation form, because that would really help us out quite a bit. And then I think something else came into the chat. So I'm just going to open the... So I think that there's another question here in the chat. So have you seen biologics cause malignancies or cancers in your practice, is the question that was put in the chat.
Well, the skin cancer, there's a possibility. Do the dermatologist do routine checkups? So that is recommended if patient have been on anti-TNS for 5 years or something, then you may send them to a dermatologist. But all the dermatologists do not do it. I've done it a couple of times and they say, oh, there's no need for that unless there is a problem. If you see a lesion that is abnormal or something like that, then send it. But that is a recommendation. With regards to patients having any other type of cancers, yes, patients have. But the thing is that there's never a way of figuring out if it is because of the medication or it just happens on its own. Because over the studies, it hasn't shown that the solid tumors are because of the disease or because of the medication themselves. It is just happened. Yeah, we have lots of patients with like breast cancer, lung cancer is a common thing. And, but generally, there's no association between the two that has been raised as through the cross cancer, any of the oncologists, that this is because of your medication. I've never come across that.
Mm-hmm. Thank you so much.
No problem at all. Thanks a lot.
Awesome. So with a little bit of time to spare, because I see the questions are slowing down, I just want to take some time to thank Dr. Akbar. Thank you so much for your presentation and for sharing all of this wonderful information with us and answering our questions. It's always excellent as a family physician to be able to hear these things and refresh your knowledge and learn new things. So thank you for taking the time this afternoon to share with us. And again, for everyone, as you're exiting the webinar, please do take time to do the evaluation form. We sincerely appreciate it. And thank you all for your attention and for joining us this afternoon. It's been a pleasure.
Thank you so much. Thanks a lot. Thanks a lot. It was fun doing it. Thanks a lot.
Thank you.